Hey everyone, and welcome to today's Explainer. Today, we're diving straight into the holistic puzzle of amputation rehabilitation, specifically looking at the gripping clinical realities of Case 13. We're going to unpack a really comprehensive occupational therapy approach to lower limb amputation. And look, this isn't just about physical recovery, right? It's really a masterclass in navigating complex multi-morbidities, massive mechanical adaptations, and some seriously profound psychological shifts.
But to truly grasp this case, we have to start with the emotional reality. Listen to this quote from our patient, Mr. Ahmed Hassan. He said, "I don't even want to look at my leg. I'll never work again." I mean, think about that for a second. An amputation is never just a physical loss. For a 58-year-old provider and a highly skilled tradesman like Mr. Hassan, whose entire livelihood is tied directly to his physical capabilities, losing a limb triggers a completely devastating identity crisis.
So here is our roadmap for today's Explainer. We'll meet Mr. Ahmed Hassan, assess the hidden risks, formulate the rehabilitation plan, go over interventions and adaptive equipment, tackle the discharge identity crisis, and finally, navigate autonomy and risk. Part 1. Meet Mr. Ahmed Hassan, the intake and multi-morbidity matrix. Okay, so Ahmed's profile is incredibly complex. He's a 58-year-old self-employed electrician, and he's just 3 weeks post-op from a right below knee amputation. But on top of that, he's also battling type 2 diabetes, peripheral neuropathy, hypertension, and stage 2 chronic kidney disease. So we are managing vascular, metabolic, and renal risks all at the exact same time. Fluctuating blood sugars and hypertension can severely delay wound healing. And that kidney impairment? It causes fluid retention that actually changes the swelling in his limb on a daily basis. And remember, before this surgery, he was completely independent, driving, doing heavy electrical work, and easily navigating the 2-story home he shares with his supportive wife.
So before we even step foot into his hospital room, we use something called the CPPF, the Canadian Practice Process Framework. This helps us establish a therapeutic relationship and kick off a really thorough chart audit. We're tracking his blood glucose, evaluating the surgical skin closure, monitoring renal clearance, and checking for early signs of phantom limb pain. And crucially, we have to be acutely aware of his remaining left foot. Because of his neuropathy, that intact limb is at incredibly high risk for ulcers and infection.
Moving on to Part 2, Assessing the Hidden Risks, the Clinical Presentation. To capture a full clinical picture, we've got to run a massive battery of assessments. It's a really delicate balancing act between gathering functional data and managing his intense avoidance behaviors and grief. We use tools like the COPM to identify his top priorities, like, getting back to dressing, driving, and work. We also do a residual limb analysis to check on healing, functional observations to see how he actually moves, and a vocational analysis to break down the sheer physical toll of his electrical business. But here's the catch. We have to tread super carefully, because confronting all these new functional realities can cause severe emotional fatigue and major body image distress. Now, this next part is actually fascinating. It's a surprising mechanical reality about his center of gravity. When you lose a lower limb, you lose about 3 to 4% of your total body mass. What that does is shift your balance point upward and backward. So if Ahmed pushes a standard wheelchair forcefully, or even just leans back, those front wheels will literally lift off the ground. It's a severe backward tipping hazard. To fix this, we install amputee offset plates. This simply moves the rear axle about 5 to 8 centimeters backward. It's a brilliantly simple adaptation that realigns the wheelbase with his new center of gravity, completely restoring his safety.
Part 3. Formulating the Rehabilitation Plan, the CMOP-E matrix.
We rely on the CMOP to build a 3-dimensional matrix of Ahmed's life. It's a dynamic framework that forces us to look at exactly how his physical changes, his daily tasks, and his surroundings are constantly colliding with one another. And when we map that out, our core diagnostic statement reveals a pretty harsh reality. Under person, yes, his cognition is perfectly intact, but he is battling neuropathy, phantom pain, and just massive grief. Under occupation, we see a sudden, complete halt to his self-care, his business, home maintenance, everything. And for his environment, well, he has a wonderful, supportive wife and good institutional funding, but he's blocked by huge physical barriers, like 2-story stairs at home and uneven construction sites at work. So the core problem here proves this isn't just about a missing leg, it's a total disruption of his independence and his identity.
Collaborating directly with Ahmed, the team locks in these SMART goals to really carefully pace his recovery. We start small, but absolutely vital. By week 1, we want him mastering seated lower body dressing.
Week 2, applying a limb shrinker, and, crucially, inspecting that highly vulnerable left foot every single day. Week 3 is all about safe wheelchair-to-toilet transfers, and this all builds towards safely completing a simulated morning routine by discharge, which eventually leads to an outpatient prosthetic assessment at the 8-week mark.
Section 4. Interventions and Adaptive Equipment, the Comprehensive Strategy.
This is where we bring in an incredible array of Canadian CMEC enablement skills, like engaging, adapting, and educating. We adapt his environment by putting a padded elevating limb support board on his wheelchair to keep his knee extended. This is huge because it prevents hamstring contractures that would make wearing a prosthetic leg impossible later on. We also use graduated compression to manage the fluid. And get this, we initiate a nerve desensitization protocol where we gradually expose that hypersensitive limb to varying textures, everything from really soft cotton to rough burlap, paired with scar massage. And obviously none of this happens in a silo. It takes intense teamwork with physiatry, PT, social work, dietetics, and prosthetics.
But what about his livelihood, right? To save his identity as a provider, we literally have to re-engineer his vocational tasks. We bring in rolling utility carts for his heavy tools, and we swap out those dangerous ladders for highly stable, adjustable platform podium stands. Most importantly, though, we coach Ahmed on actually shifting his business model. Instead of doing the heavy manual labor himself, he can pivot to project estimations, blueprint reviews, and supervising apprentices. It keeps him as the boss, right at the center of his business. We also empower his wife with visual skin check guides and get them both connected to an amputee peer mentor network for support.
Section 5. The Discharge Identity Crisis, the Twist.
So just 1 week, literally 1 week before discharge, Ahmed suddenly shuts down. He tells the team he doesn't even want a prosthesis. Then his wife calls, totally frantic, saying he's completely stopped doing his exercises and he refuses to let me look at or touch his residual limb. I don't want strangers coming into our house. He is absolutely rejecting the idea of home care nurses visiting.
We are now on a massive, highly dangerous collision course. On one side, Ahmed is asserting his autonomy. He is deep in grief and absolutely has the legal right to refuse care to protect his privacy. But on the other side, the medical risk is off the charts. If he refuses daily skin checks and swelling management, he is at an incredibly high risk for joint stiffness and severe tissue breakdown, not just on his surgical leg, but on his left foot too, which has no sensation due to the neuropathy.
Which brings us to Section 6, Navigating Autonomy and Risk, the Ethical Resolution.
Seriously, take a second and think about this dilemma. How do you balance a patient's absolute medical autonomy with the imminent risk of severe tissue breakdown? If you push him too hard, he fires you and loses all his care. But if you step back entirely, he could easily develop a severe infection and end up right back in the operating room.
Well, here is the gold standard professional response. First, the therapist brilliantly pivots by reframing this refusal. It's not stubbornness, it's grief. Validating that preserves the therapeutic trust. Then, they clearly separate basic limb health from the idea of getting an artificial leg, explaining that compression and skin checks are really just for seated comfort and infection control. They shift the focus fiercely to protecting that left foot so he can stay independent in his wheelchair. And to respect his privacy, they actually cancel the home care nurses and schedule outpatient clinic appointments instead. Finally, they document everything objectively: his preferences, his mental capacity, the education they provided, and the newly modified discharge plan.
Just to zoom out for a second and put this into perspective alongside some other clinical scenarios. While a stroke case might be all about balancing mobility with neuroprotection, or a driving evaluation case like Case 8 forces us to balance confidentiality with a legal duty to report, this amputation case challenged us in a totally different way. We had to manage profound post-amputation identity issues, completely redesign mechanical centers of gravity, and safely navigate care refusals rooted in intense body image distress.
I want to leave you with this one final thought on the really delicate, beautiful balance of healthcare. Does educating a patient obligate them to follow your exact plan? Or is the highest form of care empowering them with the facts and then allowing them the absolute dignity of risk? Thanks for joining us for this explainer, and definitely keep questioning the complexities of care.